for both EGFR exon 20 as well as HER2, I think, as you quite astutely point out, we're seeing more and more active treatments. And that's a sharp contrast from how the field looked even 5 years ago, where we really only had chemotherapy for a lot of our patients. With the rise of multiple different treatment strategies, including antibody-based strategies, tyrosine kinase inhibitor-based strategies, and antibody-drug conjugates, the field is increasingly crowded. I think the challenge that we really have is that we know that all of these treatments are active. They can potentially benefit patients. What we don't know is what is the superior treatment in the frontline setting, and how do we sequence those treatments? What do we start with? What do we follow with in the acquired resistance setting? I think it will be very important to have comparative studies going forward in order to understand what is the optimal treatment initially and what is the best treatment for acquired resistance. The treatment characteristics that I would look very closely at are going to be not only just clinical benefit in terms of response rate or progression-free survival, but also things like toxicity and tolerability, effect on brain metastases, as well as the ability to combine potential treatments in the frontline setting and the later line setting. So right now, I don't have a satisfying answer to your question, but I'm hoping that with additional clinical trials over the coming years, we'll be able to identify the optimal initial treatment and acquired resistance treatment. It is a nice problem to have in contrast to how things looked 5 to 10 years ago.